Dear guests, welcome to the Call to Europe and panel debate on Health Union. The COVID-19 pandemic caused unprecedented disruption and had an impact on various aspects of our lives. Mostly overloaded is the health and social care system. Until this point, only in Europe we had more than 265 million confirmed cases, and sadly more than 5,240,000 deaths. We can openly admit that nobody was well prepared for this pandemic. Response from governments and local authorities was far from coordinated and in following the best practices based on current evidence. Although COVID-19 virus and its variants affected every nation the same, our response, measures, and population behavior was not. If I can call COVID-19 a borderline virus, where somebody had no consequences upon infection, but others lost their lives, then we have seen a positive correlation between effectiveness of pandemic management and trust in governments. We can also see strong evidence and effectiveness in public healthcare system, and also, of course, a need for universal health coverage. Gaps that we had in our healthcare system have become deeper and wider. COVID-19 has by itself contributed to the population decline of health. For example, life expectancy has decreased for the male population within the EU for the last year. In addition, we can see progressive rise of health inequalities, unmet needs, and accessibility to general health care. Again, for example, in Slovenia, we have, in the first two waves of pandemic, diagnosed 30% less cancer diseases, which, of course, it doesn't mean that we are healthier. As such, key questions are, what happened? Where are we? Where can we go in the future? And of course, do we have progressive ideas? Health is a basic human need, but health care has remained a marginal policy for the European Union. Inequalities and divergence across countries highlight the need for closer integration of health policies and shared responsibility for healthcare capacities. Our panel, as lectures and a debate today, will focus on experience with dealing with this pandemic, IT in the health system, public health network and investments, and of course the vision for European Health Union. For this and other important questions, proposals and ideas, I'm welcoming distinguished colleagues to this panel. Mihály, former Minister of Health, Senior Fellow of the Global Health Program at the Graduate Institute of International and Development Studies. Nina PIRNAT, former Director of the National Institute of Public Health. Vytenis ANDRIUKAITIS, former European Commissioner for Health, Food and Safety. He'll be joining us online. And Timon, FORSTER, a PhD candidate in International Relations, Freie University from Berlin. So, colleague, please join me. And at the beginning, for the first opening words, I would like to invite Sara CERDAS. She's a member of the European Parliament from S&D Group, Vice Chair of the Special Committee on Beating Cancer, and a member of Committee on the Environment, Public Health, and Food and Safety. Sara, are you with us?
I am here. Good afternoon.
Welcome. The floor is yours.
Thank you very much. Good afternoon, everyone. It's such a pleasure to be here with you today, and allow me to share a few remarks about the work we have been developing here at the European Parliament concerning the European Union for Health. This has been one of the great demands from our political group since the beginning of the pandemic, that we need to be more prepared in regards for health policies in the EU, and we have asked for a European Health Union. How have we been doing this? There's many lessons to be learned from the COVID-19 pandemic, but I would like to just stream a bit with you through the different programs that we have been approving here at the European Parliament. First and foremost is the EU for Health program. And just before speaking a bit about health and the European Health Union, it's important to clarify that provision of healthcare is a competence of each member state, and that sometimes is confused with health is a national competence. Provision of healthcare is a national competence. However, the protection of public health is a shared competence between member states and the European Union. And this is where we are working on in order to strengthen the European Union for health matters and be better prepared for the future pandemics and the future crises that we'll have in health. For that, we have been working the EU for Health program. I have been the shadow rapporteur of the S&D group for this program that has a standalone budget of 5.1 billion euros. And just for you to have an idea, before the pandemic, the proposed budget by the Commission was of 500 million euros. So it was an increase in a tenfold due to the perception that health cannot be seen as an expense. It should be seen as an investment. So this program has 4 general objectives and 10 more specific objectives. And it's a standalone program for the next 7 years until 2027. Has first objective is to for disease prevention and health promotion, and for international health initiatives cooperation. Second objective is to tackle cross-border health threats, make us more prepared, more resilient as a European Union, more coordinated. I'm going to speak more about how is this translated into legislation further on. Third objective is to improve medicinal products, medical devices, crisis-relevant products, to improve accessibility and of course deployment. And the fourth objective, which relates a bit to the provision of healthcare, but seen through a public health perspective, which is to strengthen healthcare systems, to strengthen their resilience and the efficiency of those resources, so we can have better coordination at the European Union. So on regards of serious cross-border health threats, we have a European Health Union package after this EU for Health program that has been launched, and it has 3 pieces of legislation to reinforce the mandate of EMA, the European Medicines Agency, to reinforce the mandate of European Centre for Disease Prevention and Control, ECDC, and third, the one I'm working at the moment, which is to for serious cross-border health threats and to make us more resilient, better prepared, and with a more efficient response for future serious cross-border health threats. So these 5 are the ones that have the European Health Union umbrella. And we're also working on the new European Beating Cancer Plan, which has objectives which aim to tackle oncological diseases at all the steps. And we're focusing as a progressive group in those 30 to 50% of deaths by cancer that could have been prevented. And we still don't know 50% of the risk factors for cancer. So there's a lot of work to be done. The report is going to be voted this week in the European Parliament. I'm very hopeful because many of the progressive perspective is in the report. Thanks to the work of our colleague, and the next 2 proposals that will come will be the pharma strategy that we already had the initiative report, and the European health data space. So a lot of work has been doing in regards of legislation and initiative reports in regards to having a more resilient European Health Union. But this needs to be hand in hand with what we already had at the local, regional, and national level. So the aim here is not to level down, but to level up in the sense that we need to converge and we need to go beyond what we have, and our resources need to be pulled together in order to have better efficiency in response. Today is COVID-19. We're also tackling cancer. We must not forget the biggest killer in the European Union are cardiovascular disorders. We must not forget non-communicable diseases. Our citizens are asking, 70% of European citizens want to see more health policy in the European Union. And just to have you this brief remark, this is what we're working on here at the European Parliament. And I hope we can have a fruitful debate here now at this session on how we can proceed further on.
Dear Sara, thank you very much for your time and contents that you are able to share with us. We will continue now. For a decade before the COVID pandemic, DJ Sanko research projects took place in the EU, followed by joint actions aimed at improving the EU preparedness and response to cross-border health threats. Slovenia had been actively participating in many of those projects. Nina, we would be interested in the joint action, European joint action, which addressed the cross-border health threats. What were the results of this joint action and how did they contribute to the control of the epidemic?
Thank you. Thank you for your question. Good afternoon to everybody. Yes, before the epidemics, there were many joint action in the UA and cross-border management on health threats aimed at networking, early detection, mutual information and action. Within the JET projects, a number of instruction, number of recommendation and protocols were created related to chemical, biological and nuclear risks. During the COVID period, the contexts for the most of joint action part were redirected to protocols, recommendations and instructions for the control of COVID. At the beginning, it was very important to establish control at the points of entry. The joint measures were related to shipping, air and passenger traffic. But later, in the epidemic, became extremely important topics: risk communication, communication with the public, demonstration of good practices between EU countries, and at the end, demonstration in good practice how to communicate vaccination. I would especially like to highlight two joint actions, SHARP and Healthy Gateway. SHARP, that means Strengthened International Health Regulation Preparedness in the EU. This 3 years project has started just before pandemic on April 1st, 2019, with the participation of 26 partners from European Union countries. The main goal of this joint action was to strengthen the implementation of the international health regulation with an emphasis on preparedness and response to serious cross-border health risks. This included monitoring, identifying, preparing, and responding to risk to human health. The emphasis will be on education, exchange of good practices, implementation strategies, and strengthening the implementation of health regulation at all levels in the country. SHARP project partners also work with representatives of ECDC and WHO and was connected with other joint actions already underway on 2020 and related to meeting the requirement of the international health regulation. With Healthy Gateway, EU, YAMRAI, biological and chemical terror attacks 2020, and so on and so on. The another joint action, Healthy Gateway, and the aim of this joint action was to support cooperation between different countries in order to improve capacity in preventing and combating cross-border health threats, infectious illness, vectors, chemical accidents affecting or arising from traffic at points of entry into countries, ports, airports, land border crossing. So very important in both joint action I have previously mentioned is rapid exchange of information in the case of cross-border health risk, using electronic means through established communication network for entry points. Numerous activities in prepared products were carried out. Preparation of guidelines, catalogs of best practices, validated action plans to be implemented by member states, health authorities at operational level in the field of transport, covering all types of health threats. But the really good will be when this will be implemented in EU member states. As very important, I see the development of common EU platform and passenger tracking application, digital passenger location form. A number of expert groups were held as part of both joint action and part of SHARP. We learn a lot about new variants of coronavirus, exchange experience on border action. Many preparedness and responses exercises were organized according to prepared scenarios. And then we identified a lot of gaps. Then there is no central role of organization in Europe as European Center for Disease Control can be when passenger goes through European countries. There is no role as CDC in United States. There were many workshop organizations, organized risk communication workshops, vaccination exercises, and so on and so on.
Nina, thank you for this. I have an additional question to ask. Have you identified any examples of good practices? And as such, have those practices been those important practices in the countries that were successful? And what about in the future? Where do you see the role of the European Union in this and other future pandemics?
Yes, thank you for your question. Before I started with good practices from some European countries, I have to mention the study in Nature. It was published still 1 year ago in November 2020 about the effectiveness of non-pharmaceutical measures reviewed and evaluated, where as many as 6,069 measures was evaluated from 79 countries from all over the world. Research has shown that in the first period of early epidemic, that means from January to July 2020, in the world, effective measures were prohibition of small gathering, confinement at homes, restricted access to areas and places where people stay longer, such as closing shops, restaurants, restricting meetings and gathering, compulsory work from home, closure of educational institutes. However, these measures have only temporarily restricted the entry and spread of the virus. However, due to its nature, the virus cannot be stopped. So, these measures were only short-lived. However, it turned out that the radical measure had a number of harmful consequences. For example, the closure of school has interrupted the educational process, led to deterioration of diet, stress, and social isolation in children. In many countries, the confinement of people in home has greatly increased the level of domestic violence, which has had a marked impact on women and children in particular. At the same time, it also affected the health and survival of patients by restricting access to health care, that we have seen also in Slovenia. Isolation has increased social distress, mental distress. But practically equally effective, but much cheaper than lockdown due to this study are measures. Active communication with various public, measure for education and communication campaigns. The public needs to understand how individual measures contribute to reducing the spread of the virus. The public needs to understand self-protective measures about transmission of communicable disease. Therefore, people should be encouraged all the time to observe hygiene measures, ventilation, no socializing in enclosed, poorly ventilated area, and so on and so on. Communication needs to be tailored to target audience. The population to occupational safety guidelines and protocols for managers and health professionals has excellent results in curbing the spread of the virus. It is especially important to tailor communication to those groups that play a predominant role in promoting the spread of COVID-19, that was younger adults, students, employers. The survey highlights that all of these measures are not binding government advice. At a much lower cost of implementation, however, they have a similar effect as restriction, costly, mandatory measures undermined by military police penalties. So in European countries, we have seen very, very different situation. The countries with good practice was, for instance, Iceland, Finland, Norway, Sweden, Denmark, in Portugal in vaccination promotion. Iceland explicitly pointed out the need to constantly answer of citizens' questions. Communications need to enjoy a high level of trust. They say, if we found out that the measure was wrong, we say so. We confess, admit it, and tell the public how it's better, how to proceed. Finland has constantly warned about trust. They say action must be just in time and clearly communicated. In the implementation and communication, it is necessary to involve a representative of those who carry them out, students, representative of employers, NGOs. The Finns says, thank you for wearing mask, and you are not obliged to do it. Thank you that you understand that you can prevent the transmission of communicable disease. Sweden has constantly measured the population confidence in the measure. The measure were mainly based on recommendation. Denmark and Portugal have perfect vaccination campaign, and they try to explain people why it's so important to vaccinate themselves, why it's so important to vaccinate themselves because of herd immunity and also to help system. There are cases of good practice. And you have asked me what will be in the future. I think that in the future, all that recommendation, protocols, all the documents which have been prepared due to joint action should be put in practice. That's really a challenge, how between European countries use these documents. I think that ECDC should play a different role as it plays today. Because, as I said before, on the table exercise have shown that patient data and cases are lost in the event of cross-border crossing. The ECDC needs to play a greater role in governments itself at EU level. As I have previously said, CDC in United States, that means not be only advisory organization, be also a governance organization. Of course, that European joint action to tackle cross-border threats must be pursued, in particular due to emergence of new variant, SARS-CoV-2 variants. The DPLF and the Common European Platform for Exchange of Information should be used and implemented through member states as an important part of early warning response system. That is very, very good, DPLF, but only 2 countries have implemented it. 11 are thinking about it and trying to do something, but another 14 are thinking about it. I also should point out that interlaboratory cooperation between countries is extremely important. Cooperation in science and development at EU level, paramount importance. Ensuring the supply of medicine and vaccine must continue with joint EU procurement of vaccine and medicines. But for the end, the most important for me is communication, because communications is key for controlling the epidemic. And I think there is a biggest challenge for the EU as well, improving communication skills between countries and improving communication skills in their own country at national and regional level.
Nina, thank you very much for this. And now we will continue with 2 presentations. Firstly, presentation from Timon Forster and his colleagues, Health Inequalities in Europe, setting the stage for progressive policy action. Timon, the floor is yours.
Thank you very much. Great. First of all, thanks a lot to FEPS, Progresiva and the Friedrich-Ebert-Stiftung for organizing such an interesting event, such a timely event. And I'm delighted to be here today to share with you some of the insights from a project that I've done with Alexander Kentikelenis and Claire Bambra. And we've done this work on health inequalities before the pandemic. So I think what I'm doing with this presentation, with this research, is basically that we're taking a step back. We're taking a step back and looking at the broader picture. We're setting the scene and try to understand the context in which we are now discussing the policies for the post-COVID recovery. And according to some measures, the European people today are healthier than ever before. To give you just one example, if we consider life expectancy, and here we're seeing a few selected European countries in 2010. If we then look at the changes in life expectancy at birth over time and look at the figures in 2019, we see that all across these countries, and this is true for all European countries, life expectancy has increased, and sometimes markedly. But we also know, and Branko has mentioned this in the introduction, that with the COVID pandemic, in certain countries we've actually seen for the first time in decades a decrease in life expectancy. And we need to keep this in mind. So not all is good on this front. And of course, what we also see here, when we look at the variation between countries, we observe that there are substantial inequalities in health. And we can look at this in a different way. Here, again, plotting life expectancy on the y-axis against GDP per capita, basically a measure of income. And what we see here is that for these European countries, on average, life expectancy is higher in richer countries. And conversely, life expectancy is relatively lower in Eastern European countries on the left-hand side. But it also means that when we're looking at this curve, many Eastern European countries are still on the steep end of the curve. And so an increase in income would presumably be associated with higher life expectancy as well. And this is an illustration of health inequalities between countries. But equally, we do see inequalities within countries. Here, we're looking at self-reported health. The blue points for each of these countries reports the proportion of individuals in the total population who report their health as good or very good. And what we also see with the red and the grey dots to the left and to the right of the total population is the proportion of individuals by income quintile. For individuals in the lowest 20% of the national income distribution, how often do they report to be in good or very good health? And conversely, for the top 20% in the income distribution. And here it's the case that, well, the proportion of individuals reporting good health increases with income. Across all of these countries, what we see is that in the top income quintile, there are many more people that report to be in good or very good health relative to individuals from the bottom quintile in the income distribution. But still, there is considerable variation. Again, if we compare these countries, or if we look at the EU average, for example, there is variation. So let's consider the European Union, and here we have 60% of individuals in the bottom income group who report to be in good or very good health at the time of the survey, and almost 80% of the high income quintile. And similarly, when we consider Slovenia, and these are figures from 2019, the most current available, almost 1 in 2 individuals of the bottom income quintile reports to be in good or very good health. And this is in stark contrast to individuals of the highest income quintile, where we see almost 4 in 5 reporting to be in good health. So as I said, there are health inequalities between, but also within countries. And then of course the question is, well, how can we make sense of these health inequalities? How do we understand them? And what we typically see is that we can conceptualize these health inequalities as following a social gradient in health. Across many different measures of health outcomes, plotted on the y-axis, we see a relationship with social standing, socioeconomic background. I've just presented to you self-reported health and how it varies by income quintile. But we could also look, and we will do later in the presentation, at other measures of socioeconomic background, whether it's level of education, for example. And here we're depicting 2 societies of type A and type B. What we see in society A is that there is hardly any relationship between socioeconomic background and health outcome. In society A, it doesn't matter for your personal health in which class you're born, where you're born geographically, which gender, in which time. Whereas in society B, there is a steep curve, and with increasing with a higher social class or socioeconomic background, it is a key determinant of your personal health. So what we ideally want is we would want to level up and flatten the slope or the curve of the social gradient in health. And as I said, this is just a schematic representation of 2 different societies. But of course, in reality, we do observe countries that follow more or less steep social gradients. For countries of type A, we typically think of France or Denmark, where we have a strong social welfare state, where we have a safety net when it comes to unemployment. And for countries of type B, we could think, at least according to certain health measures, we could think of Latvia or Lithuania. But what we'll see is that in any European country, we do observe these health inequalities. And depending on which measure we're looking at, we will find a more or less steep social gradient. But ultimately, what we should aspire to do is implement policies that get us closer to societies of type A. So I've mentioned that we can look at different health outcomes, and here I just want to highlight non-communicable diseases. What we're looking at is now a measure for social standing or socioeconomic background is the level of education. And we're looking at different non-communicable diseases such as depression, diabetes, obesity. And we're using individuals with tertiary education, a high level of education, as the benchmark, and look at the relative risk of individuals with lower levels of education. So here, for example, we do see, when we speak about depression, a gap in the relative risk versus individuals with tertiary education. And in particular, someone with low level of education is about 3 times more likely than someone with a university degree to self-report depression. And we see that there is also, across the board, across these measures, there is a more or less steep gradient. And these are figures aggregated at the European level, but we can also look at specific measures by country. What I'm presenting here is the risk of being a daily smoker, of smoking at least 1 cigarette a day. Again, individuals with high level of education is the benchmark, and we're looking at the relative odds or likelihood of individuals with lower levels of education, whether they are more or less likely to be a daily smoker. And what we see here, for example, is again wide variation, and Slovenia is a very particular interesting case. Because what we do observe is that between individuals from low and middle level of education, there isn't really a statistically significant difference. They roughly have the same likelihood of being a daily smoker. But compared to individuals with tertiary education, they're almost 3.5 times more likely to be a daily smoker. And importantly, this doesn't only hold for smoking, but for many other health measures. We observe similar patterns when we're looking at the alcohol consumption, for example, when we're looking at physical activity, or when we're looking at the consumption of healthy food, where it's the inverse social gradient. Well, we have all these different social gradients within countries, between countries. We know that different health outcomes follow a different trajectory. But what really determines these health inequalities? And this is important, of course, when we talk about solutions. And institutions do matter, which I take to be a positive, because it means that, of course, we can alter the trajectory. We can try and level up society of type B to the society of type A. And what we visualize here is different determinants of the social gradient in health. On the left-hand side, we have social and health policy, which we all know has a direct impact on health outcomes through welfare provision, through the configuration of health systems, whether individuals are asked to pay out of pocket if they want to see a general practitioner, whether there is gatekeeping in terms of specialists, or whether there is universal health care available, universal health coverage. And these are the direct effects. But it's very important that we also think broader about the policies in a given country, because economic policy has very important indirect effects, both on social and health policy, because it basically defines the framework in which we can manipulate or change social and health policy. If we think about fiscal policy, whether there are austerity measures in place where we need to cut expenditure also in the health sector. But it's also indirectly through the social determinants of health. These are the conditions in which we live, age, work, study. And to give just one example, labor market deregulation also has these indirect effects, because it does affect or it does influence our social determinants of health, and in turn translates or manifests in changes in the social gradient. And again, I take this to be good news, because we can change these conditions. So let me give you just briefly one example for each of these types to better understand what we can do and what the variation in Europe looks like. So first, on the role of health systems, we're looking again at a different measure of life expectancy or mortality. And in particular, these are the number of avoidable deaths had a particular healthcare system being in place. So basically, a minimal mortality that if we do have a good enough healthcare system, then there are a number of avoidable deaths that we can avoid. And here we're seeing that Eastern European countries, many of them have lower health expenditure per capita, and they're on the downward-facing slope of the curve. So for these countries, it's reasonable to expect that if we increase health expenditure per capita, we do see an effect, we do see an improvement in health outcomes. For other countries, on the right-hand side of the curve, it's a little bit more difficult because it goes beyond the health system. As I've said, there is also economic policies that impact the health. So let's turn to these next. And here, I think we all know that there is lots of variation in terms of unemployment across European countries. And we don't necessarily need to speak about those per se, but what we need to consider is the associated health effects. So if someone today becomes unemployed, how does it affect his or her personal health? And this is data that we're plotting here. Basically, the expected decrease in self-reported health if someone loses her or his job. Again, what we see is that there is a lot of variation across Europe. For example, Denmark, one of the champions of the social welfare state, we see that there's hardly any effect. Slovenia is somewhere in the middle, alongside Portugal or Lithuania, but we also see other countries such as Romania or Croatia, where there is a much more substantial effect, a much more substantial expected decrease in self-reported health due to unemployment. But it also needs to be said that these effects in terms of substantive significance, they're much smaller than when we look just purely at the difference in levels of self-reported health between the employed and unemployed, because we draw many important positive sources from work. And this is one example of the social determinants of health. So good work, good working conditions, a stable and secure job has loads of positive effects on your personal health. It is associated often with higher wages, with an increase in self-worth because people like what they're doing. And it also leads to very important social networks, meeting friends at work, getting to know family at work, and also discussing certain health issues in the realm of your work. So these social networks are very important also when we think about how to navigate the health system, which in many countries can be very complex. And if you come from abroad, for example, then you're really grateful for people to tell you how to go about doing this. On the other hand, precarious employment has many downsides that adversely affect your personal health. It is associated with increased stress and insecurity, long working hours, and lower wages, all of which adversely affects your self-reported health, because it also means that you have additional exposure to issues in terms of mental health issues. And one example of precarious employment, and this is what I'm plotting here, is temporary contracts. What we see is, both for men and women, the share of employees that have a temporary contract. And here it's important to highlight that these numbers refer to 2016. So over the last few years, we've seen some changes, and particularly during the pandemic, again, we've seen considerable changes, just because temporary contracts, precarious employment conditions were most at risk. But it's good news that Slovenia, in this case in 2016, on average, the share was above 15%, and up until 2019, it was reduced until about 12.5%. But again, what we see is that there is a lot of variation across Europe, and it does matter for health and health inequalities because of the good and bad things associated with work. Well, but why should we care at all about health inequalities? You may be wondering, because at this stage, of course, there are differences between countries, within countries, but why does it matter more broadly? Well, it matters individually, but also collectively. Individually, good health empowers people. It enables us to make better, more informed decisions about our lifestyles, about how to navigate the health system, about how to access and utilize help. But also collectively, healthy individuals, they are more likely to contribute to community work, to the way that we organize ourselves in our daily lives. On the contrary, ill health has many adverse effects, again, at different levels, We can think about it at the individual or community level, where employment opportunities, status, and social connectedness all decrease. They're all at risk if you're constantly feeling unwell. Families and communities, they suffer from ill health, but there are also, of course, associated welfare costs with ill health to finance treatment. And importantly, there are also economic costs. So it's not only about making a moral or ethical argument, but it's also about economics. Because there is a huge cost of absenteeism in organizations if people are chronically ill. There is unemployment and lower productivity, all associated with ill health. So we should try and level up these gradients and decrease inequalities. Before I make my final point on the progressive agenda, on things that we can do, maybe let's just very briefly consider whether the pandemic has made things worse. And of course, we've already heard it, and it's unfortunately no great surprise that with COVID, or since the pandemic has started, health inequalities have widened massively. And this is due to two related but separate reasons. One is the features of the pandemic itself. If we look at virus-related infections and mortality rates and the spread of the virus, there are certain individuals that live in vulnerable situations, and they are more likely to contract the virus because of their work, if they're working in hospitals, for example, but also because of preconditions. So the virus tends to hit the most vulnerable the hardest. And there are also health costs that are more difficult to bear for individuals who are already vulnerable, because some of the non-COVID related operations had to be postponed, for example. Some services are not available anymore. And this is more difficult to cope with for individuals with lower socioeconomic background. But there is also a second dimension, and this pertains to the policy responses. And we've also heard that just now, with the important research that is being done on the different measures, whether lockdowns are associated with higher health inequalities, and they certainly are. And in the short and medium to long term, we also need to think about how we finance the recovery from COVID economically. Because if we go back to a pattern where we have austerity measures, where we try and reduce government spending, then it is very likely that economic losses such as job loss or income loss will follow, and this will, again, it will exacerbate health inequalities. So let me end here with some ideas of what a progressive policy agenda could look like. I think what's important with these elements is that they pertain to the different sources of health inequalities. I've spoken about health and social policy. So of course, we need to aspire for universal healthcare coverage in Europe, in all European countries. But it's also important to keep in mind the economic policies, and here particularly labor market deregulation is important. And under the presidency of Slovenia in the Council in the European Union, we've made huge progress in terms of minimum wage regulation, for example. And this is important because it leads to better work, and this is likely to reduce health inequalities. And we can also talk about other social determinants of health, such as access to education, which we've also heard during the pandemic, because of lockdown measures, has taken a hit, particularly for the most vulnerable individuals. And let me end here. If you want to learn more about this, on the FEPS website, you will also find our report, which includes additional materials, visualizations, and information on these health inequalities. Thank you very much.
Timon, thank you very much. Building on your findings, we will continue with a presentation from Mihály, who will address us with the European Health Union, Will Pandemic Lessons Accelerate Health Integration, a viewpoint from Hungary.
Thank you very much. I think I will ask the colleagues, to move the slides, because that would really be easier for me. Is it possible? Yeah, okay, and I will tell you when. So as you have heard, I'm from Hungary, which has its own troublemaker, Mr. Orbán, in the top government job, who has never prioritized healthcare and over-politicized the pandemic response. I'm going to talk about the need for the European Health Union in the light of the pandemic lessons. Can I have the next one, please? Yes, here you can see the outline, and you could see that what I'm going to speak very briefly, so I will a bit skip on the historical notes, but I'm going to talk about the measures that have been taken and are still possible, the pandemic experience, the lack of coordination in Europe. And I will give you some information about the Hungarian healthcare and present the results of a Hungarian poll on the healthcare union in Europe. I will quickly explain why health integration is important from the global health perspective. Next one, please. So let me skip the historical notes and just confirm that. And you have just heard this excellent presentation of the previous speaker on the health inequalities. And these inequalities in health and healthcare impacting the economic potential of member states forced it out that at least public health became a shared competence between the Union and its member states. However, I think that has been the case. Thanks to the European Social Democrats, the EU social dimension has been strengthened, and the European Pillar of the Social Rights of 2017 clearly stands for the universal health coverage. So these antecedents led to the concept of the European Health Union, which content is constantly growing, however, in a slower pace than desired, as member states very often want to keep health policy under control with the slogan of national sovereignty. Next one, please. At the pioneering initiative of the S&D group, in particular István Ujhely of Hungary, the European governing institutions adopted the first measures of the European Health Union, including the strengthening of the ECDC and the European Medicines Agency, the development of a new cancer control program, announced the new pharma strategy, and launched a new European Health Emergency Preparedness and Response Authority, the HERA. Disputes have already arisen between the Commission and Member States over HERA's remit. The former speaks only of an administrative unit within the office. MEPs advocating for the health union want a strong agency, but some member states, unfortunately, fear the renewal of the power battle between the EU and the member states. And all this is a sad example of political selfishness, I'm afraid. Next one, please. Many more measures remain to be taken, perhaps the most important of which is the development and introduction of the European minimum standards for quality health care. The definition of the European health minimum, the creation of the standardized rules, the reorganization and development of European and national care systems according to a uniform set of criteria, all aim to ensure access to the highest possible level of health care, not just in the frame of constitutional fundamental right. It should be a real measure that depends to a large extent on the economic performance of a given member state, but with the same technical and legal content for all EU citizens. The implementation of this program can also be facilitated if, according to the recommendations of the manifesto, a civil initiative, which you might hear a little bit more from the former Commissioner Vytenis, I think the status of health policy in the European treaties is strengthened with provisions for a European health union. And I think COVID-19 could be a wake-up call in this regard. Next one, please. The pandemic response of the European Union and its member states is a prime example of the lack of common unified action in some of the cases. The countries behaved in a panicked and hasty manner following political consideration. I don't know, you can put maybe the next one, some of the figures. No, it's not over there, I'm sorry. But, okay, in Austria, for instance, 70% fewer people died from the pandemic than in Hungary. Yet they reacted with complete lockdown to the outbreak of the fourth wave, while Hungary introduced only slight restriction. However, as you all know, there have been some success stories as the joint vaccine purchase or the introduction of the EU vaccination certificate. Next one, please. There were huge differences in the distribution. I'm afraid that the figure is not shown, however. Something has happened over there. There should have been here some nice figure, okay? But you probably all know this association between the rate of the fully vaccinated people. For instance, by November, Portugal and Ireland fully vaccinated over 90% of adults, while Bulgaria could perform only 30%. And then, of course, in the figure, which cannot be seen for some reason, I don't know why, unfortunately, the higher the vaccination rate, the lower the death rate. Of course, this association is influenced by the type of the vaccines, the health status of the population, and other factors. Okay, now, according to a survey that could really be seen here, the European citizens were satisfied with the EU pandemic management. Argue that if the European Health Union had prescribed a common health policy during a pandemic crisis, there would have been no fragmented country-specific policy-driven pandemic response. We would be more advanced in curbing the pandemic, at least in the 27 member states, with much more transparent and accountable measures, risk-based restrictions, and uniform technical protocols. Next one. Moving to Hungary, the health system has been a neglected area for years. And let me just show you two comparative graphics from a 2019 publication. I hope you could see here. Next slide, please. Oh, that's again something which you cannot see, but I will tell you that life expectancy at birth is almost 5 years shorter than in the EU, with enormous gender and socioeconomic inequalities. It is estimated that around 30,000 deaths could be prevented each year through more effective public health disease prevention intervention. And the next slide, which I'm afraid the figure will be also missing. Next, please. No, it is here. I don't know what has happened. Some figures could really be seen, others cannot be. But okay, maybe someone didn't want you to see. But here you can see that Hungary spends much less on healthcare, both in absolute terms and as a percentage of its GDP than the EU average. And just over 2/3 of health spending is provided by the state. And you remember in the previous presentation, you could see that how much the health spending is association really with some basic health indicators, life expectancy, mortality, etc. So in the light of these data, next slide please, it is not surprising that Hungarians lay people and professionals have high expectations of the European Health Union. We carried out a research with the support of FEPS, as well as some Hungarian institutions of the Hungarian Socialist parties, a little bit to find out that how Hungarians, how the professional organizations and the local governments think about the concept and the concrete measures of the European Health Union. Next one, please. The results with some explanations are available from the website of the FEPS. Time allows to raise some highlights only. 6 out of 10 respondents are rather dissatisfied with the conditions experienced in the Hungarian healthcare system. Next one. 7 out of 10 respondents support the establishment of the European Health Union. It was interesting, with no differences in educational attainment or the place of living. Next one, please. 9 out of 10 respondents rather agree with the statement of Hungary should much more spend on its healthcare system. Also agree with the statement of that there is a necessity of minimum requirements in healthcare system which should be provided by all the member states. Next one, please. 61% of respondents said that if the European Health Union were established, their opinion of the European Union would rather improve. I'm not going to further details because of the lack of time. Next one, please. We also made 6 recommendations to be considered in the process of further developing the European Health Union as follows. A 5-year program and timetable for implementation of the European Health Union should be developed. There is a need for a well-designed communication campaign. Then it is worthwhile conducting similar research in several member states. Then greater emphasis should be placed on disadvantaged groups, particularly regarding their accessibility to care. And then it is necessary to strengthen the EU's commitment to disease prevention. And finally, last but not least, the fiscal space should be created for the implementation of the components of the European Health Union. This is underway, as we have heard it at the beginning. So before summing up, let me point out, next one please, that the creation of the European Health Union could strengthen the global position of the European Union itself. A special World Health Assembly was held last week to launch the elaboration of a worldwide pandemic treaty. The European Union, with the majority of its member states, took a forward-looking role during these deliberations. With the pandemic, the world has experienced how the geopolitics of global health have immediate and ruthless repercussions for the lives and livelihoods of billions. The challenge of a pandemic treaty negotiation process, which will begin soon, is to be responsive to these interconnected levels of geopolitics, and EU should do and could do a lot for positive outcomes. Next one, in conclusion, the European Health Union is already emerging and must be shaped by progressive forces, combining attention for national welfare arrangements with strong commitments to fighting inequalities in health within a country as well as across the countries, as we have heard just before by the previous speaker. The current public health crisis provides a chance to increase EU health competencies and persuade reluctant member states to cooperate. It is a public and professional expectation that minimum standards of quality care and the minimum level of health expenditures be defined. Finally, next one, please. Let me recall a message from late John F. Kennedy. He said that the problems of the world cannot possibly be solved by skeptics and cynics whose horizons are limited by the obvious realities. We need men who can dream of things that never were and ask why not. So there is a need for committed, courageous, and visionary people for making the European Health Union a reality. I thank you.
Mihály, thank you very much for your presentation. We are honored to have a former European Commissioner for Health and Food Safety with us. He's online. Vytenis, I hope you can hear me.
Yes, I hear you.
Yeah.
Okay. Do you hear me? Colleagues?
Small accident, but nothing.
Small accident, but everything is okay.
Do you hear me?
Okay, we will continue. If we look forward to the future and connect to the Mihály's lecture, how can you comment on the vision for a European Health Union?
Yes, of course. Hello, once again. Do you hear me?
Yes, we can hear you. Did you hear my question?
Okay, I heard your question. Thank you very much indeed. First of all, I will be more than happy to be, together with you, but unfortunately it was impossible. My time frame was very, very difficult. I had no chance to go into Ljubljana, but online it's also, maybe it's a good. Thanks a lot for all three previous speakers. I fully agree with all messages, including messages about pandemic situation, about lockdowns, about also impacts on public health, mental health, and so on. Also including about issues about social inequalities, and especially I thank Mihály KÖKÉNY this really brilliant presentation. And now you know what we can tell to our audience. It is very simple and clear message from our side. If we will continue like today, we will see, very slow progress in the future. And we all know that different scenarios can be envisaged to achieve health and well-being of all Europeans. First of all, measures to make progress in health concentrate on what can be done with existing legal, financial and managerial instruments, upgrading already functioning institutions, and improved implementation of already agreed policies. And today, if you see on the activities of the European Commission, they are doing issues in scenario A, in this direction. A little bit improving ECDC, strengthening mandate of EMA, proposing some, instruments related to pharmaceutical strategy, proposing cancer strategy, and also raising questions about establishing of HERA. But if we need to do more, then we need to fine-tune existing instruments of health policy in parallel to the development of secondary legislation and establishment of new institutions that can create added value for European health. As just Mihály showed, that lack of activities in some areas of legislation is crystal clear. Why is such lack of activities in area of legislation? Because of member states have no appetite to do more together at intergovernmental level, at council level, and European Commission has no right to move forward because limits enshrined in Lisbon Treaty are so big. As you know, EU is has faced very big constitutional asymmetries. A lot of powers in hands of Commission and in hands of councils and in hands of European Parliament in area of internal market and economy, and very big powers speaking about social issues, and very limited powers speaking about public health measures. If you just can show Article 4 of the Treaty on the Functioning of the European Union, such article speaks about common safety concerns in public health matters. That's all. And the Union shall have competence to carry out action to support, coordinate, or supplement the actions of member states. Very limited powers. And of course, it is not enough to see scenario B to develop strongest European health union. And if we wish to build genuine European health union, we need to go into scenario C. Europeans decide that in addition to A and B scenarios, scenario C is needed, where the status of health policy in the European treaties is strengthened, with provisions for a European health union incorporated into the Treaty on European Union, giving the European Union explicit competence in health policy in very concrete areas, while preserving the principle of subsidiarity as a core. Of course, we need to elaborate a much broader concept of the European Health Union, going beyond a narrow proposal focused on crisis preparedness and response. And, we need to strengthen the role of health policy in the European treaties. The objective is to keep in mind a more proactive and more preventive health, more solidarity in public health activities. And it is only one way to look at European instruments: community method, intergovernmental method, and democracy method. We need to strengthen capacities in the European Commission. We need to encourage member states to build much better coordinated approach using intergovernmental method at European Council's level. And we need to strengthen European Parliament powers, presenting more, progressive views on European Health Union. Second, safeguarded European Union solidarity with sufficient capacity. We need to avoid shortages of medical supplies, shortages of healthcare personnel, and shortages in services. Expand the cross-border healthcare directive. We need that European Union share also some responsibilities in care and cure in the areas of rare cancers and rare diseases, while, of course, preserving subsidiarity as a core principle. It means that if we are building European Health Union, we can strengthen member state sovereignty in area of health care, delivering to people care in areas of rare diseases, rare cancers, because no one country is capable to deliver it to their citizens being alone. Health of European Union needs stronger evidence-based national health policies, inclusive governance with people acting as patients and citizens, and stronger European health policy together. Togetherness is only one way move forward. And health should appear on the preamble of the Treaty of the EU in parallel to internal market and economic and monetary union. Now it is out of game. Let us amend Part 3 of the Article 3 of the Treaty on European Union. And let us amend Part 2 of Article 4 of the Treaty on the Functioning of the EU by explicitly indicating shared competences between the EU and member states in the area of public and human health. Article 168 of the Treaty on the Functioning of the EU should be well tuned according to above-mentioned amendments of Treaty on the EU. It is very revolutionary situation. If we will enshrine into preamble only a few words, as you can see on the screen, and environmental and health protection, and to implement policies ensuring the advances in non-occupied and social integration are accompanied by parallel progress in other fields. And if you will put health in the Article 3 of the EU, only 2 words after and improvement of the quality of the environment and human health, it shall promote scientific and technological advance. And you can find all materials which are presented speaking about our idea to put forward the European Health Union. You can see here Manifesto for European Health Union, explanatory memorandum to Manifesto for European Health Union, and We prepared position paper, treaty change for a European Health Union. You can find all our proposals and all our grounds why we need to move in the scenario 3, amending Lisbon treaties, encouraging member states to deliver health and well-being, to their citizens. And it is in line with citizens' perception about possibilities to be much stronger as European Health Union. Thanks a lot.
Vytenis, many thanks for your presentation, which captured our previous presentations and our debate. Because of the time, I will now conclude our debate. Thank you, dear colleagues, and best regards to our viewers. We shall continue with a short break and return exactly at 5 p.m. with a panel debate on a free media moderated by Tanya Kershevan-Smokvina. Thank you very much.